Assalamu alaikum wa rahmatullahi wa barakatuh. Today let us discuss the topic of syncope. It is a vast topic, but let us wrap up it uh, uh, very in a very concise manner. Okay, so let's begin with the name of Allah. First, coming to the definition of syncope. So, what is syncope basically? Transient self-limited loss of consciousness due to global cerebral hypoperfusion. Okay, what are the key features in that? It is rapid onset. Remember that this is transient loss of consciousness and it is self-limited due to hypoperfusion. It is rapid in onset, short duration, spontaneous, complete recovery is there. Pre-syncope is nothing but the prodromal state of feeling of faint. So impending faint is pre-syncope, okay, without any actual loss of consciousness. Pathophysiology is same as rough TLOC. What is the epidemiology? 1 to 3% of ED visits, 6% of hospital admissions. Lifetime cumulative incidence is up to 40%, nearly 50%. Okay, any person has a probability of maximum up 40% to have syncope in his life, and it has a bimodal age of distribution. What is that bimodal age? So in adolescents and young, usually the vasovagal syncope is responsible, whereas in elderly more than 50 years of age, mixed causes are responsible. Mainly drugs and cardiac causes are responsible in adolescent patients. Let us come to the physiology of baroreceptor reflex. This is important, okay, to know the pathophysiology. So you can see here, I will scroll it, I will zoom it up. Just see here, this is the afferent pathway of baroreceptor reflex. This is the efferent pathway of baroreceptor reflex. So there are receptors which are situated in the aortic arc and in the carotid sinus. They always continuously sense the blood pressure, blood volume. Okay. So whenever a patient stands from the supine position, there is fall in BP because of gravity. So that continuous sensations, so the afferent pathway is carried out by the glossopharyngeal nerve, which is showed here by these blue lines, and the vagus nerve. These two are the afferent pathway for baroreceptor reflex. Okay, they relay in the nucleus of tractus solarius (NTS). So there is continuous sensing of the BP, and accordingly there is uh, adjustment of the heart rate and tone of the vascular muscles. So when a patient gets up from the supine to standing position, he will not faint or he will not feel pre-syncope, because immediately that fall in BP will decrease the impulses which are going to the nucleus of tractus solitarius. So that has connections with caudoventral lateral medulla and connections with vagal nerve. Okay, what this will do? This will decrease the impulses through the vagal nerve, and as we know, vagal activity suppresses the heart rate. So when there is decrease in BP, so there will be decrease in the impulses going to the heart via the vagal nerve. So heart rate will increase. Heart rate will increase. Okay, and some impulses will go to the uh, paraventricular nucleus, okay, and supraorbital nucleus, which will secrete the vasopressin. Again, vasopressin will cause vasoconstriction of the blood vessels. Okay, and also there is activation of the, there is increase in the sympathetic autonomic nervous system activity that causes vasoconstriction. So this increase, so the total response is increase in heart rate and increase in sympathetic activity, leading to increased vasoconstriction. So both of this will cause increased BP. So a normal person with normal autonomic activity will not have any pathologic, without any pathology, without any autonomic failure, will not have any symptom when he will stand from supine to standing position. Okay, so because of this baroreceptor reflex. So any of the any pathway if it is affected. For example, if the afferent pathway is affected, or the efferents are affected, or the central mechanisms are affected, then there will be a problem. When these are affected, we will learn in the causes of syncope. Now moving forwards. So whatever the mechanism, the final common pathway is reduction of the, for the syncope is reduction of systolic BP to approximately 50 mm of Hg. Okay, reducing the cerebral blood flow below the autoregulatory threshold. You know what is autoregulation of circulation in the brain? You know, the brain adjusts to decreased PP. So the brain adjusts to decreased PP as well as increased PP, so that the intracranial pressure is not increased or the blood supply to the brain is not decreased. That is auto-regulation in the brain which is there. So it has some threshold. To some extent it will it can tolerate decrease in BP, but when the blood supply falls below the threshold, that is approximately 50 mg or less than 50 to 60 ml per minute per 100 gram, then patient will have pre-syncope along with that TLOC or syncope. Okay, so the final common pathway is decreased cardiac output, decreased systolic BP. Now determinants of BP are cardiac output and systemic vascular resistance. So whenever there is decreased cardiac output due to some causes or decreased in systemic vascular resistance due to vasodilation, then there will be decreased PP. That decreased PP will cause syncope. So BP decreases, example for decreased cardiac output are due to arrhythmias, structural heart disease like aortic stenosis and hypertrophic cardiomyopathy, volume volume loss due to dehydration, okay, or due to blood loss, increased thoracic pressure like cardiac tamponade. So what happens in tamponade? There is massive pericardial effusion that will not allow the heart to fill up. So the end diastolic volume will be reduced. When the end diastolic volume is reduced, cardiac output will be reduced. When the cardiac output is reduced, there will be decreased PP. And pulmonary embolism. So when there is pulmonary embolism, again there is decreased in the pulmonary circulation. Pulmonary veins will bring up less blood to the left ventricle. That left ventricle will pump less blood. That will cause syncope. So these are the causes of decreased cardiac. So mainly the cardiac causes and intrathoracic causes will cause decreased cardiac output. So decreased vascular resistance. So due to vasodilation can be due to vasovagal reflex. It can be due neurally mediated. Just remember as neurally mediated, or due to autonomic failure, or due to some medications. So these three will cause vasodilation. Okay, medications will also cause vasodilation. Autonomic failure will also cause vasodilation, as well as neurally mediated mechanisms will cause, means neurally mediated syncope will also cause vasodilation. So cerebral autoregulation, as I have explained, it is there. When the blood flow is decreased for more than 6 to 8 seconds, then that will cause syncope. Role of posture. So standing posture, when a patient stands, there is a high risk of chance of syncope. Why? 500 to 1 liter of blood is pooled in the lower limbs. So a compensatory baroreceptor reflex, increased sympathetic tone or decreased vagal tone, is required to maintain the BP. Okay, so if a person stands for a long time, so they'll be pooling of blood in the lower part of the body, decreased venous return, decreased cardiac output, and then syncope. So these are the mechanisms of syncope. So what are the EEG changes? EEG, electroencephalographic changes you see in cases of syncope to differentiate it from seizures. Okay, so two patterns are observed during syncope, indicating hypoperfusion but not epileptiform activity. So one is slow fat slow pattern, second is slow pattern. Slow fat slow pattern is, first there will be high amplitude slow waves, then EEG flattening, attenuation with, and then returning of the slow waves, more severe in hypoperfusion. So here you can see there is slow waves coming here. Okay, here there is normal activity, here there is slow waves, then the EEG will become flat, as you can see all here. Okay, and then again there is returning of slow waves. So this is the one pattern which you will see in EEG. What is the second pattern? Slow pattern, only increasing and decreasing slow wave activity, increasing and decreasing slow wave activity. That is the second pattern you will see in EEG, increasing and decreasing slow wave activity. There will be no flat waves. Okay, slow fat slow pattern, only slow pattern will be there. And also you can notice here you can notice, see, When this is done in a patient, this is taken in patient with undergoing tilt table test. What is tilt table test? We'll learn. BP gradually it will decrease when the table is raised to approximately 70 degrees, and a time comes when the BP will fall less than 50. Okay, at that time there will be appearance of slow waves. Then the BP will rise. Okay, this is the first one. And what are the EEG changes? EEG, when there is syncope, there is asystole. The heart rate will fall, and suddenly there is uh, temporary cessation of heartbeat, that is asystole. Again there will be returning of heartbeat after that. So that changes you will notice in EEG. This is important. Okay, now we will, so that was the mechanisms of syncope. Now we will go to the classification causes of syncope. So there are mainly three main categories of syncope. One is neurally mediated syncope, or also known as reflex syncope. Okay, second one is orthostatic hypotension. Third one is cardiac syncope. So this is important. Why? We are evaluating a case of syncope in order to know whether there is any cardiac cause for the syncope, so that it is treated. Otherwise patient will have a long term mortality for that. So the whole stuff we are doing to rule out any cardiac life threatening cardiac cause of syncope. Okay, so neurally mediated syncope, it is seen in approximately 25% of cases. It has an incidence of 25%. Pathophysiology of neurally mediated reflex syncope: the afferent pathway is normal, efferent pathway is normal, autonomic nervous system is normal, but it is hyperactive, it is sensitive. So what happens is, to some external activity, there is paradoxical vasodilatation and bradycardia. Vasodepressor and cardio inhibitory action, cardio inhibitory response to some external trigger that should not trigger this neurally mediated syncope. That is triggering because in some cases, some patients, in some individuals, that neurally mediated syncope, the autonomic nervous system is hyperactive. Okay, in those persons this will happen to some external trigger. So based on that external trigger, we will classify. We will have subtypes of this neurally mediated syncope. Number one is vasovagal syncopes. Vasovagal, as the name suggests, it is due to vagus nerve. Okay, this is provoked by emotion, pain, fear, sight of blood, or those static stress. What will happen because of this? There is increased sympathetic activity. These are nothing but fight, flight, okay, or fear response. No, so in these conditions there is increased sympathetic activity, very much increased sympathetic activity. Normally there is very much increased sympathetic activity. So what will happen is, there is increased uh, contraction of ventricles to raise the BP. Okay, contraction of ventricles. But what will happen? The contraction is there, but there is no blood. So there is contraction against less blood in the heart. So when there is excessive contraction of the ventricles, there are some mechanoreceptors in the ventricles. Those mechanoreceptors will send signal. Those mechanoreceptors will sense signals, as though the blood volume is very much high, the BP is very much high. So they will send signal to the autonomic nervous system, saying that the BP is so much high, as though there is no high BP because of these external triggers. There is very excessive contraction of the ventricles, but the mechanoreceptors will sense it as high BP and send signals to ANS. ANS, what it will do? It will decrease the heart rate, as well as it will cause vasodilation. So that will cause syncope for some time. This is the mechanism behind vasovagal syncope. Okay. So common faint. Then is situational syncope. So some posture, some situation will produce syncope. It can be pulmonary, it can be gastrointestinal, it can be urogenital. Again, here vagus is the vagus is the afferent. So there is cough, commonly swallowing, or defecation, or micturition. So these can produce syncope, cough syncope, Accordingly, it is called micturition syncope, defecation syncope, swallowing syncope. All these you can see. Okay, this is situational syncope. Second is carotid sinus hypersensitivity. So in some individuals, here there is bifurcation of common carotid artery. No, in that there are receptors, baroreceptors. So in some individuals, it is hyperactive, hypersensitive. So when it is pressed from external side for due to some reason like some tight collar or some tight tie, that will sense it as high BP, and the vagal tone will be reduced, and sympathetic vascular resistance will be reduced. That will cause syncope. So tight collars, shaving, turning of head. Okay. So these are the neurally mediated syncope because of hyperactive autonomic reflex. So what are the clinical features? Very important in order to differentiate. Clinical features, there will be prodrome, important, because in cardiac cases there will be no prodrome. No prodrome. What will be the prodrome? There will be nausea, there will be sweating, and lightheadedness. This is the prodrome. Prodrome will be seen in neurally mediated syncope or reflex syncope. Okay, and you can also see it will, there is no there will be no convulsive activity, but some brief myoclonic activity and stiffening may occur. If that occurs, then that it is called as convulsive syncope. That is not actually seizures, but it can occur sometimes. Okay, for less than 30 seconds. Okay, so just remember, there is actually there 99% of time there will be no myoclonic activity, but if it is there, then it is called as convulsive syncope. It will last for less than 30 seconds. So the differentiating features, it is highlighted. There will be a prodrome, and there will be rapid recovery. Rapid recovery, within seconds the patient will wake up, because when the patient falls, the venous rhythm to the heart will increase, and cardiac output will be corrected, and that will increase the BP. So there will be prodrome, there will be rapid recovery, and it rarely causes injury. Now the prognosis in these patients is excellent. There is no increased mortality in these patients. So this is a picture of, again, of tilt table test. Sorry, this is a picture of tilt table test in patients with chronic autonomic failure as well as acute, means orthostatic hypotension. This is orthostatic hypotension, this is chronic autonomic failure. As you can see here, there is fall in BP. Okay, but after some time, there will be delayed increase in BP. Okay, delaying of increasing the BP, that's why patient will experience symptoms of pre-syncope and sometimes syncope. That is orthostatic hypotension. Now you can see here the BP is falling and falling and falling and falling, but very much delayed. Means it looks like there is no increase in BP. The BP is falling and falling and falling. So this is seen in chronic autonomic failure, where the baroreceptor reflex is very much hampered. Okay, this is in orthostatic hypotension, where there is delayed response of baroreceptor reflex. Here there is failure of baroreceptor reflex. Okay. Second subtype is orthostatic hypotension, 10% incidence. What is the definition? Sustained reduction of BP more than systolic BP more than or equal to 20 mmHg, and diastolic BP more than or equal to 10 mmHg within 3 minutes of standing. Within 3 minutes, there should be a sustained reduction of BP, which should produce pre-syncope or syncope. Then it is sustained reduction of BP of more than 20 systolic or more than 10 diastolic. That is orthostatic hypotension. Now you can divide it as initial orthostatic hypotension and delayed orthostatic hypotension, as we have discussed in that diagram. So initial is within 15 seconds, very early, very transient mismatch, but it is not due to autonomic failure. Symptoms occurring after 3 minutes, persistent symptoms occurring after 3 minutes of tilt table test, orthostatic hypotension, then that indicates early autonomic dysfunction. Okay, symptoms which occur more than 3 minutes, that is an early sign of autonomic dysfunction. This is very important point. Okay, so what is the pathophysiology in this case? There is chronic failure of autonomic reflexes to maintain the BP on standing, and lack of appropriate compensated tachycardia is a key feature. Okay, chronic autonomic failure is the pathophysiology in this what do you call, orthostatic hypotension. So more than 3 minutes, that is an early indication of, if the BP falls after 3 minutes, that is an early sign of autonomic failure. Important point. What are the causes? Said the causes can be neurogenic, means number one is autonomic failure. Number two is hypovolemia. Number three is medications. Number four is postprandial. Okay. Autonomic failure can be primary due to neurodegenerative, like in Parkinson's disease, and secondary failure can be due to peripheral neuropathy, which you can see in patients commonly in diabetes. Okay, commonly in diabetes, and here it is commonly Parkinson's disease. Other causes include amyloidosis, autoimmune neuropathies like in connective tissue disorder or Guillain-Barré syndrome, or multiple sclerosis. All these causes. HIV is also an important cause. Okay, vitamin B12 deficiency, which will cause demyelination of nerves. So that is also an important cause. Remember, the most common cause is diabetes, and primary cause is Parkinson's disease. Hypovolemia, medications which cause vasodilation, and after eating food, because the blood is diverted towards the GI tract. So again, because the blood is pooled in the GI tract, blood flow to the heart is reduced, that will produce syncope. What are the clinical features? Clinical features are important because it differs in all types of syncope. In vasovagal syncope, there will be a prodrome and rapid recovery. In orthostatic hypotension, what will be there? Here also there will be prodrome, dizziness, lightheadedness, and there is something called as coat hanger headache. What is coat hanger? You have that coat hanger, no? Like this in homes, in almaris. In almaris, you will have this coat hanger where you attach your coat here, like this coat. Okay. So this type of headache, why this coat hanger headache, why the name is given? So because the you will experience this headache in orthostatic hypotension. There will be, this is nothing but occipital region. Okay, there will be occipital headache, and there will be pain in the bilateral shoulders. So this is something representing a coat hanger. That's why it is called as coat hanger headache. So there will be pain in the occipital region of the head and in bilateral shoulders in patient with orthostatic hypotension. Okay, and this is one important point. There will be prodrome immediately up. This is important. When what is the posture? Immediately upon standing, when the patient stands from the supine position, postural. So postural, the patient will have prodrome. Okay, there is nothing in neurally mediated syncope, no postural kind of thing. But here in postural, there will be postural syncope. So that is very important point. And patient will have supine hypertension, because most commonly it occurs in elderly patients who will have comorbidities. The patient will have supine hypertension. Along with that, when the patient will have postural syncope. So that is the important differentiating point. Okay, see again same thing. Chronic, this is nothing but chronic autonomic failure. The BP is not raising because of failure of autonomic nervous system. Okay, this is still table test. How is the prognosis? It varies. Prognosis varies, and it is worse because patient will have associated comorbidities, and patient will have fall risk, so they can have injury to the head. Okay, like that. So this is 10%. NMS is most common, 25%. This is 10%. Second common is cardiac cause, that is 20%. Okay, 20%. What is the pathophysiology? Due to some arrhythmia or due to some structural disease that is affecting the heart, that will decrease the cardiac output, that will cause syncope. That is the pathophysiology. So as we have learned, the causes are either it can be arrhythmic or structural. In arrhythmic, it can be bradyarrhythmias or it can be tachyarrhythmias. Okay. In bradyarrhythmias, it can be primary sinus node dysfunction. So the heart rate itself is not produced. Heart rate itself is the sinus node actually produces the heart rate in the heart, SA node. So SA node discharge is less. So heart rate is less. When the heart rate decreases, there will be drop in BP. So that is known as sick sinus syndrome. And the attacks which will come, syncopal attacks, those known as Stokes Adams attack. Okay, Stokes Adams attack, or some high degree AV block or drug induced AV block. we can say, like verapamilated diltiazem, okay, or beta blockers, which will reduce the heart rate. So these are the causes of bradyarrhythmias. So that will affect the AV node or the SA node. The causes are because of AV node and SA node. In tachyarrhythmias, most common is ventricular tachycardia. Ventricular tachycardia. Okay. Second is supraventricular tachycardia. It will produce syncope only when it is fast, very fast. Okay. Or some associated structural heart disease is there, and upon that the supraventricular tachycardia is superimposed, then that will produce syncope. Or some long QT syndrome like Torsades de Pointes, Brugada syndrome. Okay. So these are all the thing. But remember, the most common is in tachyarrhythmias, ventricular tachycardia and supraventricular tachycardia. Supraventricular tachycardia. These are the tachyarrhythmias or bradyarrhythmias. Both can produce syncope. Structural causes can be obstructive or myopathic. So aortic stenosis, hypertrophic cardiomyopathy, atrial myxoma, okay, pulmonary embolism, cardiac tamponade. So all these will cause obstruction and there will be syncope. Aortic stenosis, hypertrophic cardiomyopathy, pulmonary embolism, cardiac tamponade, and atrial myxoma is rare, but you can remember common is aortic stenosis and hypertrophic cardiomyopathy. Myopathic is due to ischemia, MI, or due to severe cardiomyopathy like dilated cardiomyopathy. Okay, in India, dilated cardiomyopathy the most common cause of cardiomyopathy. Okay, either due to myopathy or due to obstruction, which are structural causes of heart disease, ischemia and cardiomyopathy and structural. So this is important. So what are the clinical features of this cardiac syncope? They will not have a prodrome. Prodrome is present in both OH and NMS, but they will not have a prodrome. They will occur sudden without warning, and they will occur during exertion. They will occur when supine, and they can be preceded by palpitations or chest pain. Palpitations or the preceded palpitations or chest pain or breathlessness. All these can be accompanied with the syncope. Okay, and exertional syncope, supine syncope, no prodrome. There is high risk of injury. The recovery is rapid if the arrhythmia terminates. Prognosis is very poor. There is high chances of 1 year mortality and risk of sudden cardiac death. So these are the definition, okay, and pathophysiology and causes and subtypes of different types of syncope. So we will learn differential further how to approach a case of syncope in the next video. Thank you for your watching.